Ira. Fine, fine. Dr. Diljan, welcome.
Thank you. Thank you, Sasi.
So there are three of us to support you.
Thank you. Thank you so much.
I think for the viewers, Diljan has a very unique story. So we'll briefly tell you about Dr. Diljan. Me and Ira will briefly introduce. So we all have heard about, or we all have not heard about the harassment faced by many doctors across the globe. So we have Dr. Professor Tim Noakes from South Africa. Dr. Gary Fetke was just our guest from Australia. Dr. Sean Baker from USA. Dr. Annika Dahlquist from Sweden, and Dr. Bordua Roy from Canada, and Dr. Antti Akila from Finland. They all have faced a solid pushback from the local establishment because they have practiced low carb or they have spoken against sugar. So we have one such case in Asia also. For the first time, Dr. Diljan Mansoor is from Nepal, and he's facing a solid pushback in his local town, in his local country. And we from D Life, since we are from this continent, we are the leaders in low carb, and we want to support Dr. Diljan to the maximum extent possible. And we have taken up this task, and we have allocated a special session even in this, so that the world comes to know about the predicament of Diljan and the solid, excellent work he has been doing. I hand over the talk now to Ira.
Hello, welcome Dr. Diljan Mansoor from Nepal. India's first metabolic health conference, low carb across the globe. Welcome Shashi, welcome Anup. Here's a brief introduction of Dr. Diljan. Dr. Diljan is an MBBS and has completed his MD in internal medicine from China. He's worked as a medical officer for more than 5 years and also as a resident doctor for 2 to 3 years now in his own clinic, and has his own clinic, Food Diabetes Heart Clinic and Research Center in Kathmandu, Nepal. He's the youngest and the only internal medicine physician who advocates low-carb diet to his patients. Recently, he was hounded by the local authorities for practicing low-carb, and they made him close his clinic. After much struggle and fight back, he's allowed to reopen his clinic, but with some restrictions. So I welcome Dr. Diljan Mansoor. I am Ira Sahai, your host. I'm a metabolic health coach based out of Mumbai. And I welcome Shashi, Anup, and Dr. Diljan in this great conversation. Welcome.
So a word from Anup first.
Yeah, Dr. Diljan, we are meeting for the first time formally here. Now, as you know, we are the only platform in India or the subcontinent, I would say, and the only award-winning platform for low carb. And we've had not many success stories. I mean, to quote a number, I would say collective, it is around 3,000 plus. Now, that's not a small feat because Indian subcontinent primarily is grain-based. And to, work with clients or work with patients on low carb for such a granitarian region, it's not an easy task. Yet, we made it possible, and welcome to the show.
Thank you.
So first up, I think I'll begin by asking Dr. Diljan about his background in brief, and tell us a bit about your medical studies and how did you come into low carb.
All right. Thank you, Ira. Thank you for having me here. It's such a pleasure to have you. Back in 2015, I was working as a medical officer after completion of my MBBS. So I was working as a medical officer in a lot of hospitals. And in 2015, actually, my dad was a diabetic and he was a hypertensive. I used to see a lot of tsunami of diabetes in my country, and it's increasing every day. And that time it was my own dad. My dad was hypertensive, and he was on hypertensive medication. He was on diabetic medication. He was on hyperuricemia medication. So, and he was a diabetic for a long time back, like 10 or 20 years ago. But in 2015, when I started to understand things, what happening with my dad, and that time it was a bit concerning. Initially, my dad was on oral hypoglycemic agents. So my dad, we couldn't control his hyperglycemia. His blood sugar was raising every day. And despite of being a medical doctor, I used to do everything by the rule, that what I've taught in the med school, what I have learned in the med school. And if it is hyperglycemic, I need to switch from one class of group to another class of group. And so despite of doing everything, despite of doing every little thing that I'm supposed to do as the doctors and my seniors, my dad diabetes was getting worse and worse. And there was a condition, I had to switch my dad onto insulin therapy. And on being insulin therapy, my dad was like experiencing hypoglycemia and the hyperglycemia. He was sometimes being unconscious because the insulin was too high for him and his diet was not controlled. So I was very skeptical that time why I'm not being able to treat my dad. And gradually my dad developed AKI, the acute kidney injury. So we started my dad on dialysis. There was time he was on dialysis. We were doing all this medication, supporting medication, plus he was having on dialysis. So it takes like an year, and there was an earthquake in my country in that same year. And 2 months after earthquake, my dad, he was in hospital. So we need to do a dialysis. So initially we had a temporary dialysis before we had a fistula. We started doing dialysis of my dad, inserting a catheter in the jugular, and we started doing a temporary dialysis. So we also were planning to go for a permanent dialysis. So we created a fistula. It takes 2 to 3 months to grow. Meanwhile, my dad had a complication, and then my dad died. And once my dad died, I was shocked, and I was first time in my life I was so hopeless, because I did everything to save my dad. I tried oral hypoglycemic agent. I put my dad onto SGL2 that was supposed to be safe for a kidney patient. Then I put my dad into ACE inhibitors, ARB inhibitors, and then we started doing dialysis of my dad. But I could not save my dad. The only question is on my mind, I killed my dad. Everything is because of me. I was so helpless. I could not even, if I could not help my own dad, like what I'm supposed to do. And I blame myself for everything that happened to my dad, because being a doctor, I could not even save my dad. He was pretty young. And then I was not in good mind, and I was started to look something beyond it. Like, what is happening to my dad? Why did he have to wind up into diabetic nephropathy? Why he had to why I could not control his diabetic despite of all the medications? And then I started digging into this low carb community. And that time I was a medical officer, just an MBBS doctor. So then I joined my residency in 2017. I joined residency after 2 years. I could not even work for 2 years. And I was so traumatized, and like I could not even process everything that happens to my dad. I did every little thing that I was learning in the med school. I did everything that I was supposed to do as a practitioner, as a medical doctor. Then I started my residency. And during my residency, I was in Fujian Medical University. It's like in the cardiac department, as being an internal medicine resident. And I used to see the tsunami of diabetic. And every time I see a patient with diabetic, it reminds me of my dad. I used to think that guy is going to wind up just like my dad. He's going to have a diabetic nephropathy after a few years. Then he will be on dialysis, or at the end of the day, he will renal transplant. And I could not sleep for like months and years, thinking all the time there should be something that I should do. And then I started digging into low carb community, and the first person I came to know was Dr. Diljan. So I started digging more and more, and then I finished my residency. I was so much prepared. Once I'm going back to my country, I'm going to start I'm going to start low carb for my metabolically ill patients. So I started treating them with low carb food, and the response was so immense and so beautiful. I used to see my patient, they're thriving on low carb diet. Their hyperglycemia has been controlled from 4 to 5 oral medication. I used to taper their medication to 1 or 2 medication. From 60 to 100 unit of insulin, I used to put my patient on 10 units of insulin, and it's working so good. And that is the beauty of being an internal medicine doctor, because I have idea about the medicine, which medicine is safe for my patient, which medicine is safe for his kidney. And within the years, I treated more than 6,000 patients, and here I am.
Excellent. So I believe that this situation would be similar in Nepal as in India. Like we have been rattling out this figure earlier also, 101 million diabetes. 136 million with pre-diabetes. The issue I probably feel is very, very similar there. So what is it you see in the general population, not in your practice, but in the general population? What all metabolic issues you see?
Let me tell you, Sashi, this is a very good question you asked me. Let me put you in the data, because these people do understand the data. In my country at the moment, the diabetic is like, it's like 1.1 million people are diabetic. I'm not talking about pre-diabetic. Forget about pre-diabetic. Almost 1 to 1.1 million people in Nepal. We call 10 to 11 lakhs. I think same in India. In lakhs, we use lakhs. So 10 to out of 30 million people, 1.1 million people are diabetic. So I was not only confined with my country, I started digging more into Asia. Look at now India is the capital city of diabetic at the moment. As you said, there's 100 million people are diabetic in India. We're not talking about pre-diabetic. And let's look at data about cardiovascular disease. In my country, 1.1 to 1.2 million people are having heart disease, like cardiovascular disease. And almost, according to the data by NIH in 2019, there was almost 46,000 people died of heart disease. And disability adjustment life, more than 1 million people are having adjusted life because of cardiovascular disease. So when you're talking about this metabolically, and when talking about pressure, out of 4 people, 1 person is having hypertensive problems. And the worst part is that only 5% of them have a controlled hypertension. So what I'm seeing right now is there will be a time, even my country or your country will not be able to handle this metabolically ill people. Our system will not be able to handle the diabetic patient. As there's a very beautiful word said by Anup earlier, graintarian, and he's so correct about that part. We are not only grain lover, but we're grain worshiper. I prefer the word worship. We worship grain, everything. And even you remember when you're harvesting the grain, we worship. It's similar culture in your country and my country. So from a grain lover, we are a grain worshiper. And at the moment, I can see there's so creeping disappointment by treating them conventionally. We are failing as a physician to treat them. Like we are trying to control their hyperglycemia. We're trying to control their hyperinsulinemia by the medication. But what is the end results? What is the success rate for that? What are you doing here? So when talking about all the data, I'm so stuck and so sad to see such a huge amount of diabetic patient in my country. Cardiovascular disease is rising, is skyrocketing. So when it comes about data, we are on the top of the roof, and we are seeing this. And I have seen a tsunami of people, and I am sure maybe after a few years we can't even handle this.
Very, very important. It is this statement of yours is going to be etched in the mind, that we are grain worshippers.
Yeah,
this is truly big. Yeah, no.
Yeah. So, doctor, you told us about, what made you go into low carb or prefer low carb. Well, you mentioned Jason Fung and others. Now, as you know, as you said, we are grain worshippers. So, low carb is a very, very, I would say, flexible term. So, in your practice, what is the carbohydrate limit that you set for a patient that comes across to you?
Thank you, Anup. It's a very good question. I always tell my patient, and I treat them individually. I see on their body mass composition, their muscle mass. Like if you have more muscle, you can tolerate more carbohydrate. And that is the very, very simple thing you need to understand. Because your muscle, when you have too much muscle in your body compared to a very lean person, you're muscular, it means you have too much of glucose transport. Well, GULT4, that's the transporter. We transport the glucose to your muscles. So if a person is very muscular, he can tolerate a lot of amount of glucose. He can store a lot of amount of glycogen. But the basic, let's talk about the rule. Your liver can only store 80 to 100 grams of glycogen. Your muscle can store up to 120 to 200 milligrams of glycogen. So when it comes about when you are a diabetic patient, you are on oral medication, you are insulin therapy, you are metabolically very healthy, you have visceral obesity, at that time of point, you need to stop eating carbohydrates. It's not only about carbohydrates, you need to stop all those extra grains, carbohydrates, pulses that is converting into the glucose, even about the fruits. Because first we need to control your metabolic health. Once your metabolic health is considered, you are in a good shape, you are according to your height and weight, you are in your normal BMI, that time we can consider, I put my patient up to 100 to 120 grams of carbs. But a lot of people are mistaken with the carbs, mistaken with the glucose. What they think, rice is the only thing that's converted into glucose. They won't care about the potatoes that they're having or the sweet potatoes they are having. The only thing they consider when talking about sugar, they consider about table sugar. You know, the table sugar. Oh, doc, they come to my clinic, you should stop these sugars. And they will tell, doc, it's been years, I'm not having sugar. Then I ask them, what do you have today for lunch? I have chapati, and then I have a bread. Oh, and whole bread, you know, that's what they talk, like they have been manipulated with the word. Oh, do you know what? One slice of bread, a 5 tablespoon of sugar in your bread? No, doc, no, it's just a whole bread. So I talk about, first you need to know what condition you are, what type of patient you are, if you are diabetic, if you're hyperinsulinemia, if you have insulin resistance, and your HbA1c, your blood parameters are way higher than it's supposed to be in normal range. At that time, I want my patient to go below 100 grams of carbohydrates. As you said, in a country like Nepal and India, people, if you tell them to stop carbohydrate, it's like a crime. You're fighting with the culture. If you tell them don't eat rice, if I'm not going to eat rice and pulse like dal bhat, then what I'm going to eat? Look, their whole scenario is created with this dal bhat. And that is creating a big problem. I said, you can have dal bhat, but before you take a dal bhat, first you need to eat the glucose inside your body. You have too much of fats, you have a visual obesity, you have a big stomach, you have a belly, and there's another source of energy that we call another source we call ketones body. So first, let me fix your metabolic health. When your metabolic health is fixed, I will let you to eat carbs. You can have legumes, low-carb legumes, and low-carb legumes, even the 100 grams of legumes have 14 grams of carbohydrate. You're taking carbohydrate. Low carbohydrate diet does not mean no carbohydrate diet. There's such a misconception with the people. When talking about low-carb diet, they will think no-carb diet. Oh, I'm going to die. My brain is going to die, because they have no idea what is called hepatogluconeogenesis. They have no idea everything that you eat in the form of carbohydrate that is converted into glucose in your body. You have another source of energy. But first, I need to tell them about the basic concept, how much glucose you need, how much glucose your liver can store, and the excess of all glucose is converted into fat. That is called de novo lipogenesis. So you need to control this part, and gradually, once they are very convinced on, I am telling them, this is not a rocket science. You don't need something to bring from another planet. You can, locally available things are available for you. We can fix it out. We can talk according to your budgets. We can fix you out. Once your HbA1c is below 5.6, once your blood pressure is under control, and then we'll keep on adding a little bit of carbs. And even adding a carbs, we are not going to add any refined and processed carb. We'll go for the carbs that is good for you. So that's the answer to the Anup. I'm telling them every time when we talk about low carb, they're thinking only the meat. Oh, if I'm not going to eat carb, what I'm going to eat? You can eat lots of green leafy vegetables, dark leafy vegetables, lots of green things you can eat, and even slowly and gradually, I can put you on a little bit of pulse, and we can consider with the paneer and the tofu. Don't worry, if you're not into meat, fish, or eggs, gradually we can change you. But first, we need to fix your disease.
Okay, Dr. Diljan, how many patients have you treated on low carb? Being a conventional doctor, how many patients have you treated on low carb, and who are they usually? I mean, what kind of metabolic disorders do they come to you with?
Thank you. Most of the patients that I see, I treat two type of patient. One is, you can see them and you can tell them, oh, he's metabolically unhealthy patient. They have visual obesity, they have big bellies, they are diabetic, hypertensive, hypertriglyceridemia, and the obesity. That is the one type of person that is, you can, by looking at them, you can tell them before doing any blood test. And another is, especially in Asia, I'm problem with this person. They are very lean, they're very thin, but they're having diabetic. So sometimes, if you heard the word tofai, thin outside and fat inside, and these people are lean, especially you go for Asian continent, they're very small hands and legs, but they have very big belly, you know, like they've got a protruded belly that time. So I'm seeing two type of person. One is very lean, an underweight person with diabetic patient, and other is morbidly obese patient. The two type of patient I have seen, and I have seen more than 6,000 of this metabolically ill patient. And once I put my patient onto low carb diet and try to taper their medication, adjust their medication, because you need to do with a very, very genuine person, a doctor who supports you, and with a doctor who knows about your medications. When I have to take off my patient of the medication, I need to understand what type of medication first I need to take them off. The first medication I take off is diuretics, because after starting low carb diet, my patient started to see there's a very, very lower blood pressure there. And once they started going hypertensive, you need to understand what kind of medication you need to taper. So the first part is like, you need a doctor who can tell you, who can talk to you, and who have a basic idea about your medication. Even I have a patient who are renal patients and they're metabolically ill patient. The renal medication that is safe for a diabetic patient in SGLT2 groups, and other is ARB or ACE inhibitors. So just it's not about taking them off medication directly. It's like looking on their blood reports with their values, how it's working, and what is the percentage of tapering, like how did you taper the medication. We talk to them and how good they are feeling. And at the moment I'm in my clinic, so I have a very special chart, especially for my metabolic patient. So I'm very keen with my patient. I want to know every details about my patient, what they're eating, what type of food they're eating, what their medication, and even I give this vital chart to all of my patients to monitor their fasting blood, their postprandial. Even sometimes some of my patients are like dawn phenomenon patients. Their morning blood glucose is very high. So sometimes I ask them to wake up at 3 a.m. in the morning and check your blood glucose. That time you might be in hypoglycemic. And once you're hypoglycemic, your liver start to make a lot of glucose. That is called hepatic gluconeogenesis. So these two type of patient, the first thing, I need to know everything about my patient when treating them. And by doing this and putting them on low carb, the most beautiful things I see when I put my obese patient on low carb diet, the first thing, their skin started to change. They started to glow. They started to thrive. When they came in my clinic, they have so much of skin tags. You can see how hyperinsulinemia, your skin has been changed. And once I put them on low carb diet, I started to see, the first thing I noticed, their skin started to become so beautiful. And then gradually start tapering their medications. First, I am very, very concerned with the patient medications and their side effects and how does it work on my patient. So, and once I put on them a low carb diet, the first thing I see, they started losing a lot of weight. Once they start losing a lot of weight, blood pressure is controlled, their hyperglycemia is controlled, and gradually after 3 months, 4 months, 5 months, 6 months, I could be able to take off the medications. And even after 6 months of off medication, they're in regular follow-up with me so I can check the blood glucose again.
Very interesting. We'll come back to that. See, like you were mentioning, what is the amount of patients you have had success with? I think you had mentioned a huge number of patients. We are very, very keen to know that how many patients and what all are the activities which you have done there.
Thank you. So out of 6,000 plus patients, most of them are metabolically ill patients, and some of them are 10% are like hypothyroid patient, autoimmune disease condition patient. And recently I have prepared 52 cases of drug-free remissions. So I'm going to publish that paper. I had a talk with Dr. David Unwin, and he teaches me last time. So I'm going to publish the paper. I'm preparing to publish that paper into New York, into NMJ, in the nutrition. So technically talking about like 90% of patients are metabolically ill. They are either diabetic or they're hypertensive or they're obese or they have hypertriglyceridemia. And the other people that I see in my clinics are morbidly obese, having problems with their spinal cord problems, their problem with their movement. They're not being able to move properly. And even out of those 90%, a lot of people have already developed diabetic nephropathy. They have started to have their microalbumin hyperalbuminuria, and some of them develops macroproteinuria, or we call macroalbuminuria. So basically 99% of my patients are metabolically ill patients, and 90% are diabetic patients, 10% are maybe hyperthyroidisms, or they're morbidly obese patient, or they're orthopedic person who cannot even walk. Or I have a lot of patients, if I'll share some of the stories. I have a patient who lost 65 kg in 1 year, and now he's playing football. So when he came to my clinic, he was in a wheelchair, and he could not even, he barely could walk, and he was 145 kg. I took a permission because I want to mention his name. To even find this morning, he was talking to me. His name is Prakash Kharel. So he was 145 kg, and now he lost like 65 kg, and he's playing football, and he barely could move. He barely could walk, and now he went to trekking, and he make a video on top of Gosai Kunda. There is a place where he went for hiking, and he make a video, a gratitude video, that I was not even being able to walk around my house. Now I am trekking on the feet of 4,000. He went to the trek. So when I talk about my morbidly obese patient, most of them had problems with their knee pain, the joint pains, their lower back pain. They could not even move, and their movements is very limited. But once they started to shed up the all unnecessary weights and the fats, they started getting very healthier. When I talk about my hypothyroid patient, most of my patients are obese patient. See, it's so interesting correlations. See, if I talk about them. So most of my patients, those are hypothyroid patients, and they're morbidly obese patients. Their BMI is above 35, 36, 37. Once they started losing weight, there's such a good like improvement in their blood parameters. The THS from 10 started getting like 6, 5, 4, and start tapering their medication. And initially they were on 50 mcg of levothyroxine, so I put them on 25 mcg, then I put on 12.5 mcg, and the report started getting better. So technically these are 5 patients I was talking about. One is metabolically ill patient, the 4 I always have metabolic syndrome patients, and other is orthopedic patient. I've seen lots and lots of orthopedic patients. Their movement is restricted due to their overweight, and they have joints pain, knee pains, and a lot. Even I see a lot of people with rheumatic disease patient. They have so much of inflammations in their body. So I always talk about them. Let's try this. Let's try this first. Let's get off all the extra weight, and then let's try to decrease your inflammation in your body, and then we'll talk about whether it's work or not. First, you need to lose 20 kg of weight, and you have too much of inflammation in your body. I check all the metabolic panels in my lab, and once I explain them about what is called ESR, what is called CRP, how much inflammation your body has, what is called insulin resistance, your fasting insulin is high, you are metabolically unhealthy. First, let's fix your metabolic things. Once I fix your metabolic things, and then we'll talk about your pain. And once you started fixing their metabolic health, they started overall improvements. Their movement start to get better. If you remember, a lot of diabetic patients have a frozen shoulder. If they have there's a restricted movement in their shoulder. So once their hyperglycemia is controlled, their blood pressure is controlled, their hyperinsulinemia is controlled, they start, doc, look, I can move my hand. And that is the most beautiful part when they come to the clinic. Oh, you can move your hand now. And so these are the patients I'm seeing.
Great. Anup?
Yeah, Dr. Diljan, besides attending patients in your clinic, are you doing anything to educate the general population in Nepal? If yes, what is it?
Yes, I'm doing it. As you know, I used to do in my clinic, so I've been restricted to do that. I cannot do.
We'll come to that, subsequently.
Yeah, like I cannot do mass counseling, so I'm doing individual counseling at the moment. The best part is I have my own YouTube channel, and especially it's in Nepali language because I want to make that videos for my patient. So I have my Facebook page where my people who are following me, or the people who are interested in the low carb community, they follows me, and especially technically to educate the people, I have making a lot of YouTube videos for my patient. And I have some certain interviews in my country that has been viewed in millions and millions for my people.
Then earlier to this, like you were doing a lot of in-clinic activities also.
Yeah, so true. I used to have a mass counseling of 30 to 40 people at a time to teach them what is low carb diet. And so before I teach them low carb things, I used to teach them what is insulin resistance, what is hyperinsulinemia, what is diabetes, and what is metabolic syndrome. I used to teach them for 2 hours about metabolic syndrome. So they are very easy to understand what I was trying to tell them, because once you teach them how to fish, they can easily fish. But if I provide them the fish, they might use that fish for 2 or 3 weeks. But again, they have no idea how to fish this. So for that part, now I'm making the YouTube videos for my patient.
Doc, I think that is superb. See, generally, we find that we have very less time inside a doctor's clinic. Just
So
get prescription. You are spending 2 hours in explaining the very basic concept. I think it is just out of the world that a mainstream doctor who is an MD, internal medicine, could actually take time out and explain to a group of people on what is the basics. And spending the 2 hours is very, very valuable. It's very rarely we have seen such doctors, really. I recall one pediatrician in Mumbai long back who used to do that compulsorily. Yeah, Ira.
Yeah. Dr. Mansoor, can you tell us what really happened, in the last 2 years? Talking about how the authorities, they objected to you practicing low carb. So give us a brief about that.
Let me tell you. Here's the story, Era. The main point is that being an internal medicine physician, or the mainstream conventional people, they think being a physician, it's inappropriate to preach or advocate about nutrition. That's the first point. Second point, low carb is unscientific. The fact is that there's hundreds and thousands of data are coming up every day, and it has been practiced around the world. When we talk about this low carb is scientific or unscientific, there are hundreds of papers are published. Even Dr. David Unwin published a paper, Type 2 Drug-Free Remission, and it's with such a tremendous results. So even we talk about low carb, it was in 1983, in 1863, William Benting, in the letter of corpulence, you first published about what is the health benefits of being on low carb diet. Even in 700 BC, the Greek Olympian used to have a low carb and high fat and protein diet to preserve their endurance, their athletic endurance. So in a country like Nepal and India, or in the Southeast Asia or the Asia, where everybody is a grain lover, and when you suddenly come out of nowhere and young doctors saying that, oh, look, if you're going to fix your diet, you're going to fix your diabetes. So it's like, you understand what I'm trying to tell. Oh, this is something wrong. We have been eating rice for centuries, and how could someone come and say you can't eat it? So that kind of mass hysteria has been created in the country, a fabricated story. Once you are on low carb diet, you wind up being a kidney patient. Your kidney is you will destroy your kidney. You'll wind up being into a kidney patient. So such kind of, and this, the media, how they have been controlled with these things, and so started defaming you and deframing you, saying low carb diet is inappropriate. As a physician, to prescribe low carb diet is unsustainable. You cannot sustain it, and it is and at the end of the day, you will double the risk of your cardiovascular disease, and you wind up being a kidney patient. But as you know, there's no any published paper that says that there is a direct relation between the low carb diet or the heart disease or the kidney disease. So this has been happened throughout the country since these 2 years, and I have to face all this alone, telling people, no, low carb diet is not going to kill you. It's going to treat you. Your diabetes will be controlled. But being alone is sometimes so hard to tell the people and explain the people, but still the fight is going on.
So now I think it's very interesting you told that in 1797, John Rollo, the notes of diabetes cases, we know that he has treated diabetics with meat and fat diet. It is so old, and even as recently, it is endorsed by even American Diabetes Association in 2019. 2018, it's the joint consensus between ADA and ESD. They declared that low carb diet can be an option. And from 2019, it is there in their MNT. I don't know how many of them open really the MNT section. People will generally see the drug algorithm, and that is what it is followed. And this is 200 years of low carb diet, 200 years. And still people think that it is something out of the world. People think it is a fad and everything. So the interesting point now is, after this protracted battle, you have done so much. You have, I think, single-handedly fought against the authorities. You have permission to open the clinic. So is there any restriction, or what are the restrictions you have right now?
I told you before, the first restriction is I should not do a mass counseling in my clinic.
Okay.
So I should not talk or preach or advocate people in a group. So they allow me to practice, but as an individual counseling, if people are ready to have a consultation with me, you can do one-on-one consultation. So like when I'm talking about metabolic syndrome, teaching 100 people at a time and teaching 1 people at a time is the same thing. So the only thing is that I'm happy as long as I'm being able to practice, as long as I'm able to, at least I'm going to make difference in someone's life. If today I'm going to make one life, like difference in one life, tomorrow it'll be the 2 and the 3rd and the 4th and the 5th, so that is the restriction. I should not do a group counseling, and I should talk about individual counseling. So these are the sort of restrictions that I have been following, but that's the restrictions in the clinic. But I can do on my YouTube, so I can tell my people what's happening to them. So see, when he talks about the restriction, that is not a big problem. The problem is that our people, the people in India and the Nepal, they're not being able to understand the glorifications of this low-carb diet to their metabolic syndrome. When it comes to metabolic syndrome, we are not only working on their obesity, we are working on their insulin level. We are talking about their obesity, their diabetes, their hypertension, and even on their obesity part. So even it's an individual counseling, my main focus is to teach them, to make them understand to how low carb is so beneficial for you. And there's not a rocket science. You can do it for a few months, you can see the changes, and it's your decision or the patient decision that what they want to do, how long they want to do. And as for my patients, see, I'm a physician, I'm ready to give you pill all the time. It's up to you. Come on, like, there's nothing, you have nothing to lose. But once this has been portrayed with the kidney disease, I want to tell you through today's interview or to our conference, to the people of India and Nepal especially, don't fear the protein. Don't fear protein. See, I'm telling you the story. You're worried about your kidney disease. Just do me a favor and Google what is the most common cause of kidney disease in the world. You'll get an answer. The first thing you pop up is a diabetic. So if diabetes is the first cause, or the primary cause could be anything for a kidney disease. You could have a tumor in your kidney, you could have a renal artery stenosis, you could have a kidney stone that leads to your kidney failure, or you might wind up in nephrectomy. So there are so many other things systemically that you can have a kidney disease. So but we're not dying of systemic kidney disease, we're dying of the secondary cause of kidney disease. So once you Google what is the most common cause of kidney disease, secondary cause of kidney disease in the world, the first answer is your hypertension. So we are trying to control your hypertension, we are trying to cure your hyperglycemia. So here is the catch to the people of Nepal and India. They need to understand it takes 5 to 10 years from pre-diabetic to diabetic, and from diabetic it takes 5 to 10 years to develop microalbuminuria. Albumin is a protein that we see in the urine. So once you start microalbuminuria, it means your kidney is losing some protein. Your kidney is not being able to filter the protein. So one need to understand it's not the protein that is causing a problem to your kidney. For example, you have a strawberry in your sieve, and you're washing the strawberry in a basin, and suddenly you see some strawberry in the basin. So you can't blame the basin. Oh, there's something wrong with the basin, or you cannot tell, oh, there's something wrong with the strawberry. It's the sieve, that a hole inside the sieve, and that's how you see the strawberry in your sink. Same thing happened with the kidney disease. Once you had a kidney disease, it's not the protein that causes kidney disease. Your protein is not being filtered by the kidney. There is a hole in the kidney. So in the first hand, what causes hole in your kidney? Diabetic nephropathy. So prolonged diabetic for 10 to 20 years, your uncontrolled hyperglycemia for 10 to 20 years, that leads to a condition called microalbuminuria. And this is the first stage, like we started developing diabetic nephropathy. And from diabetic nephropathy to wind up into other condition we called macro, that's a macroalbuminuria, or simply proteinuria. That is another 10 years condition. And these are from microalbuminuria to the macroalbuminuria proteinuria, you start seeing the problems in your kidney now. So in the first hand, what is the main problem for a kidney to progress into a kidney disease? Is uncontrolled blood pressure, uncontrolled hyperglycemia, uncontrolled insulin. So we are trying to fix your kidney here. We are trying to slow the progressions of your kidney disease, and low carb diet is undoubtedly the best thing for you. So when we talk about protein, if you have a kidney disease, and so once you start you stop eating your protein, you're not prioritizing your protein, what happened? There's a condition called protein malnutrition. Your body have 2 liters of albumin, you start swelling, your body, your cells, everything start to swell, and the condition become worse and worse. So it's not the protein. There's certain condition where we restrict the protein. For example, you have a heart failure and you are into end-stage end-stage renal disease. That is the only condition, and that is also believed 20 years ago. People saying that if you take a low protein diet, it might help, because urea is the metabolic outproduct, and that might lead to a little bit of problems for a kidney to filter all those urea, and that might, a lot of people might wind up into the uremic encephalopathy. So that is the only condition where sometimes we ask our patient to limit your protein intake. That's why you need to talk with the doctor. It's not the protein that is creating your problems. There are a lot of conditions that are creating your kidney to wind up into a renal disease. So I always tell them, don't fear the protein. You talk to the person. First, prioritize your protein, like what kind of disease you have and what kind of, if you have a diabetic nephropathy, the first hand you have to control your hyperglycemia. You need to control your blood pressure. So I always tell them, don't fear the protein. Just figure it out. What is the first secondary cause for your kidney disease?
Very interesting. And you have shown it very nicely that the microalbuminuria starts maybe after 5 years, then progressing into proteinuria. And I think that's what we say, that there is a window period of maybe 15 years or 10 or 15 years before the complication starts. And the crux of this point is, today we see diabetes setting in at a very early stage. At the age of 25, 30, 35, that means by the time they reach 50s, which is still a productive age, they face complication. Unlike the earlier time when we used to get diabetes at 55 or 60, we still had a window period of 10, 15 years. 70, 75 is okay when people were considering old age. But now into productive age, people are getting in complication, I think. And very nicely you explained it, really. That 5, 10, 15 years period. Very nice. Anup.
Yeah, doctor, you mentioned about, basically scaremongering was the route adopted by the opponents of your protocol. Now, to add to that, as a personal case, when I started talking low carb diet, discussing with the doctor, I was told within 10 years, you'll die of multiple organ failure. Now, it is 13th year, I'm still alive. Now, extending that, world tells us, or the mainstream experts, they tell us that meat, ghee, butter, everything is dangerous. So what's your opinion on this?
My opinions on saturated fat, or what is your
saturated fat, ghee, butter, coconut oil.
Let me this is such a beautiful things. Even let's talk about India, in South India. What they do, it's not about today or today. It's like hundreds of years and years ago. People are on coconut, they've been eating coconuts. And ghee is not a new thing to the people of Asia. We worship cow. And the most beautiful part from a cow is the ghee, the grass-fed ghee. Let's talk about saturated fat. Our ancestor, or we, is not started eating ghee just last night or like the 2 days ago. We have been consuming this for years and years and years. Look at our civilization. Even before there was the seed oils, we used to light during the Durga Puja. We used the light with the ghee. If you can correlate with me, there was no such things, oils, and that time people used to do with the ghee, with the grass-fed ghee. Now, when talking about saturated fat, a lot of people are scared that saturated fat does cause heart disease, or it's double the risk of your heart disease. But there's not a single paper published that says saturated fat has a direct causation with the cardiovascular disease. There's only one study done, and people have been following that study by Ansel Keys. And that was not only 7 countries, that was the 21 country studies. And how the data has been manipulated, how the data has been scattered, data has been shown in a linear graph. If you go to the study, you can find out there's no direct correlation. Let's talk about the saturated fat. Saturated fats are the healthy fats. We're not talking about you're having a meat with a bun of bread. See, and you cannot blame the meat that's inside or between the bun. You cannot take the problem with saturated fat to the people that are understanding. They're taking these things with lots of other dietary bad habits. You're having a tablespoon of ghee and having a vodka in the night. You're having 1 cup of meat and then you're having all the locals liquor. You know what happening in our country? I'm telling you, with the socioeconomic country, they will take 2 pieces of meat and then have 2 bottles of beers and alcohols. And then you blame the meat for what the sugar did. You're blaming the meat, a saturated fat, for what the food you had. So in country like mine and yours, when something good happens, we have a sweet. Like, if you see carefully how those sweets has been prepared, and you will take just a little amount of ghee, but so much of wrong dietary choices with this. You're taking this meat with alcohol, with the beer and lots of junk food, and that's been real and cooked in a polyunsaturated fatty acids. And the meat which has been cooked in the polyunsaturated fatty acids, if you know, all the seed oils, they have a very low boiling point. And if you have a low boiling point, it means they are very vulnerable to perioxidation. Once they're very easy for perioxidation, you can see they can easily break, and they can create free radicals in your body. And the free radicals can damage your tissues and your cells. It's just like that same thing happening with the cholesterol. Cholesterol is the basic for every individuals, every human beings. Our cells are made up of cholesterol. If you study a little bit of, do your homework, every human cells in the body is made of cholesterols. If there's a cholesterols on your skin, once you're exposed to the UV rays, that cholesterol is converted into cholecalciferol, that's vitamin D3, converted into vitamin. If you see your sex hormones like estrogens and progesterones or testosterone, they all are made from cholesterols. Even cells are made up of phospholipids, bilayer phospholipid. That means there's 2 layers of cholesterols in your cells. Even you see for a neonate, a baby born, that is also having a lot of cholesterol from your mother milks. So if you see carefully, even for your bile salts, you need cholesterol to make up bile salts. Even you need cholesterol for all those steroid hormones in your body to regulate function properly. Even for vitamin D, you need cholesterol to function. And the most important part is that your body, your liver makes 800 to 200 milligram per deciliter of cholesterol every day. Your body makes almost 2,000 milligram per deciliter of cholesterol every day. So once you start eating little cholesterol, your body starts making more cholesterols every day because you have to survive. Your cells need cholesterol. And the most interesting part, your myelin sheath in the brain. Your myelin sheath in the brain, that is also covered by the cholesterols. See? So once you started lowering your cholesterol level, your body started making too much of cholesterols. So cholesterols is the main function of cholesterol is to repair your things. So once you have inflammation in your body, in your blood vessels or in your arteries, cholesterol is the first thing that reaches to your artery to heal it, to fix it. So it's just like blaming an ambulance for, like, there was an accident in the road and the first person to arrive at the site might be a policeman or the ambulance. So you're going to tell, oh, the ambulance is the person who causes the road accident. So same thing happening with the cholesterol. Cholesterol is the most important nutrients in your body. You need it. Even your body to proper function, you need cholesterol. So the things that you need to understand, you cannot take saturated fat with the carbohydrates. You cannot take saturated fat with the alcohol. For example, you cannot take like all those sugary drinks and with your meat. You cannot have a tablespoon of ghee with all those fizzy drinks, because that is called perioxidation. So you should be very careful with the perioxidation. It's not the meat, it's what the meat is cooked with. Let me tell you a common scenario in our country. We cook the meat into seed oils, and then we have that meat with lots of dessert. And once we come to a festival, we have to drink a lot of fizzy drinks. We have to have alcohols. We have the soda. So what I'm telling is that we are taking the saturated fat with the wrong food, with the wrong choices. And at the end of the day, we are blaming saturated fat.
A very nice point here. What you told is, how do we cook meat? It is in a lot of seed oil. And how do we take with lot of refined grains?
So true.
Lot of rotis. the more meat you have, the more roti we need. 8, 10 rotis. And biryani, one small piece of meat and then tons of rice. So there's an issue.
And that is not the only one problem, Sashi. Let me add you the more problems here. It's not only the oil they're cooked in, it's what they're taking with. And now imagine about the spices we're using in our country. Nobody is taking coriander in the way it was. We're taking lots of refined and processed, like we have to add a lot of ketchups. Even we are putting a lot of ketchups on the ketchup and the sugary drinks, and we have to genetically modified spices, and they are been using all like all this Ajinomoto, you know, like all this packet things, which been packed with a lot of processed food. And even the new fashion, they are like cooking chickens or cooking chicken wings with the Coca-Cola. You know what they're doing? They have been demonizing the fat for something they're doing so wrong. You cannot do that. Like even once you cook any kind of sugar, it converts into Maillard reaction, and Maillard reaction is very toxic for you. And people started cooking sugars and saturated fat together, and with a lot of all of those you know, like those sauces and those ketchup and those vinegars are full with the liquids and with high fructose corn syrup. Can you imagine that? And even now they put in honey in it. You know, imagine that.
So, Ira, you can take up a couple of questions here.
Yeah, one of the questions is, I think, from Anjali, Dr. Diljan. How do you manage low carb on a veg diet? What do you do as a practice?
What diet?
Veg.
Low carb on a vegetarian diet. And if you could give some practical tips, and how do you do?
Thank you. I have more than thousands of patients that are vegetarian. Sometimes it's very hard for me, for my vegan patients. But for my vegetarian patient, I especially in country like yours and ours, we have to be very careful with our patient. When my vegetarian patient comes to my clinic, the first thing I talk to them, listen, I'm a doctor. I will respect your decision, but you have to respect mine as a medical point of view. If you are vitamin B12 deficient, you have to take supplementation or IV or oral supplementation. It depends on your values. If you are vitamin D3 deficient, if you have a deficiency in iron's profile, I'm gonna check everything and then we'll talk. So especially for my vegetarian patient, I keep them on veg diet. For example, the most of the time I ask them to take all the green leafy vegetables, dark leafy vegetables, and I ask them to take the grains and legumes. And especially for the legumes, I want them to go for sprouts. Once they're sprouted overnight, like we can decrease their glycemic index. So I asked them the 4 or 5 things. I asked them, the first thing is like go for all the vegetables except the starchy vegetables. I don't want my patient, because they're diabetic and they're vegetarian, so that already I'm not being able to provide them as much of nutrients and the protein that they need from vegetarian diet. So I try to balance them, and I try to talk to them. The first point is that I want them to go for all the green leafy vegetables as much as dark leafy vegetables. Just avoid the starchy vegetables. Just go for locally available vegetables in your location, in your region. And I always talk about region and season. You know, you have to just eat the things that is locally available in your place. And second part is I go for legumes. And once it comes about legumes, it's a tricky part. Sometimes legumes should be so harmful for my patient in case of controlling their hyperglycemia. So I ask them to my patient compulsory, they has to sprout. They has to make it a sprout. They should soak in the water for overnight. Sometimes I ask them to go for 6 days or 7 days, so you can have very good amounts, very low amounts of glycemic index in your foods. And third part is I go for them. They're like paneer, tofu, mushrooms, and the other part is I sometimes ask them to take some seasonal fruits in the country that very low glycemic index. But at the end of the day, I try to tell them if egg is possible, let's take it. Or if egg is not possible, I ask them to focus more on mushrooms and then more on the paneer and the tofu and there's a sprouts one and lots of green leafy vegetables. And sometimes I ask them to take some coconut flours and almond flours so they can change their taste. Sometimes they're bored, because they're very limited for them, especially for vegetarian. So I ask them they can make some pancake with their with the almond flours and the coconut flour. In India, in South India, I think there are a lot of coconut recipes. That's very rare here. But I try to teach them, my patients, so you can take some coconut flours and almond flours, and you can make some pancake, and then at the end of the day, ask them to take lots of green leafy vegetables and make a lot of soups.
I think we just have 5 minutes, less than 5 minutes. Dr. Anvin is also waiting. One last question which Anjali has asked. How is it that trekking guides which she has seen are surviving on dal bath and very less protein meat? How? Is it genetic or how?
This is very interesting question, Sashi. Look, part is that this is the half of the story. When talking about the trekking guide, they're not trekking 24/7. Because I have been personally involved in this trekking part. My friends are like trekking guide. What they do, there's always a time, like 3 days in a week, 4 days in a week. And most of the trekking guide, they carry lots of dry meat. If you see very carefully, most of my friends, they used to carry lots of dry meats. They carry lots of cheese, and especially in Nepal, the yak cheese, And that the saturated fats, or the fat, has 9 calories per gram, whereas the carbs have only 4 grams. So when I'm talking about the trekking part, the first part is like when talking about the professional trekking guides, they are very, very lean and healthy and muscular, and they are taking the protein part on different parts. For example, they're using lots of hard-boiled eggs, and before they're trekking, and they always carry such kind of food, dry meats and dry fish. And when it comes about their carbohydrate intake, as I told you, they're very fit, they're very lean, they're very muscular, so they can tolerate lots of carbohydrates. They can, as I told you, the more muscles you have, the more glucose you have, GLUT4, the GLUT channel you have, and you can store lots of glycogen in your muscles and in your liver. So what happening for trekking people, as I remember, most of them are taking lots of dry meats, dry fish, dry eggs, and when they're physically very active, they can tolerate a little amounts of carbohydrates. So at the end of the day, they're not trekking 7 days, 7 days in a week, that they're trekking for 3 or 4 days. And as you know, when they are trekking, the most of the time they are fasting. They're indirectly fasting, and when they're fasting, their growth hormones are very high, and the growth hormones will help you to protect your muscles.
I think that's very, and probably, as you say, though they may have a little more carbohydrate, it does get expended because of the high intense of activity which they are doing. And I think we cannot really mix this up with the average sedentary person. The average sedentary person, if he goes on and having excess carbohydrate in this form, they are sure to be in some or the other issue. So I think this is what the basic difference which I understand is from what you say, with the kind of exercise there and with the kind of dry foods which they carry, which they may be having occasionally, coupled with the fasting and everything, is really good. So Dr. Diljan, what is the message you want to give to India and to your own countrymen Nepal in this platform, both?
Thank you, Sasi. The first thing, in India, you call medicine as dabai, right? Dabai.
Yeah, dabai.
So the literal meaning is dabai, suppress. It is just suppressing your symptoms. When we call dabai, it means it's just going to suppress your symptoms. So I'm telling to my people, to the people of India, you need to take dabai when you actually need it. But don't throw the pills for a dietary disease, your lifestyle disease. The first thing is that you have to figure it out. How did you get it in the first place? If it is a dietary disease, just like you're having hypertension, diabetes, obesity, so this is your dietary disease. So you need to fix it with the diet, by fixing your diet. And the second part, to telling to my people and your people, don't fear protein. You need a lot of protein. You need a lot of protein. Having 1 egg is not enough. You're having only 5 grams of protein. First, you need to have a basic ideas. How much protein do you need? What is your daily activities? How physically active you are? These things is very important. Talk to your person, talk to your diet coach, talk to your low-carb nutritionist, talk to your physician. How much protein do I really need, doctor? I'm barely having any protein. So stop worrying about the protein. You need protein to build muscle. You need protein to slow the progressions of aging. You need protein for a lot of functions in your body. And you need to prioritize your protein. And when it comes about grain, we are not telling you don't eat grain, but don't worship it, the grain. You're a grainitarian. Even legumes have lots of carbohydrates. The vegetables we're eating is having lots of carbohydrate. The fruits you are taking is having lots of carbohydrates, having lots of fructose. So first you need to know what is your basic need, what kind of disease you are, and how physically active you are. Stop worrying and stop fearing a lot of things. Once you are very cool and calm and fix your 5 things in your life, you start seeing a very good result. First, fix your nutrition. Fix your protein in your diet. Prioritize your sleep. Have to 7 to 8 hours of good sound sleep. On top of everything, talk to a doctor to add magnesium glycinate or threonate for a better sleep. Once you have a very good sleep, you can fix a lot of problems in your body. First, your nutrition. Second, sleep. Go and walk in the sun, bask in the sun, have 1 to 2 hours of walk in the sun. We are naturally blessed with such a beautiful, amazing sun. Go outside. Get sunlight in your eyes to fix your circadian rhythm so you can have a good sleep. Don't be scared. Don't every time put on long clothes and covering your face outside the sun. Sun is there to help you.
Thank you for all the points, Doc. I think we are very happy to support you, and we have seen a very passionate doctor in Dr. Diljan, and we will have more sessions with you, and we really love talking to you. So thank you very much.